So for those viewers that don't know, this is Dr. Buinewicz, and he's from Doylestown, Pennsylvania, and he is of the plastic surgeons that's very well known in our group. How many implants have you done so far, you think?
We just looked. I just printed out new data since now I finally have time to go through all this again. So we're just starting to go back 4 years. I looked back, the first explant that I did for breast implant illness syndrome, which was one of my patients, was August of 2016. So we're almost 4 years. Looking at the numbers, about 1,200 patients.
Wow.
So it's
Wow.
incredible. Yeah. There's some looking at the spreadsheet I printed out. So probably 1,000 to 1,200 probably easily.
Okay, that's a lot of explants. So thank you for
Incredible number.
All of us. Thank you for everything that you do. We all appreciate you. So let's just I'm so happy I chose Dr. B. One of the nicest people I met. One of the things that's always said about you, Dr. B, is your bedside manner. I think that you're just really relatable, and I think that that means probably so much to most every woman that encounters you, because when we figure out that we're sick with breast implant illness, and then we find a surgeon, and if that surgeon happens to be you, you have this way of easing our minds and letting us know that we're validated in what we're feeling. And there is no greater gift than that when you're sick. So I do think that that is one of the reasons why so many women come to you, because you end up just being like just such a comfort to so many people. So thank you.
Thank you. Thank you. You're going to need the wide angle lens pretty soon.
No, I don't believe that about you. I think you stay pretty humble.
It's what I've done. I've always, it's one patient at a time. And that's how this all started with me. An experience with one of my patients who was sick, was having issues. No doctor could figure it out. She thought it was her implants. I agreed to take them out, take the capsules out. The story goes on from there, but that's where it's all started. So you can teach people medicine. You can teach people what the skills are need to be a doctor. You can't teach somebody common sense. And I guess it's empathy. You can't teach somebody empathy. I've had personal life experiences and, very recently with my dad passing, but we've all had them. Everybody has their own experiences, but the ones I've had have definitely, from what people are saying and thank you, has helped me made me a better person and a better doctor.
Awesome. Thank you.
You do have options for, a regular tram flap, unless you don't have enough skin that you could, get to take from your belly. But if you take the full muscle, you got a little bit more bulk. It's easier to build a breast. Yes, you do lose a muscle. Same thing with latissimus flap. People are doing latissimus flaps. You can get about a decent B to a small B-size cup of tissue from somebody's back. Again, you are harvesting a whole muscle. People do go to gluteus muscle. There's some other more esoteric flaps out there. So there are possibilities for sure.
Okay. All right. Cupping is always a hot topic.
Yeah. Scar wise, any type of scar, any surgical incision, minimum is 6 months. For facial scars, torso scars, a year. Extremity scars up to 2 years. So basically whatever external scar you have, when it is soft, white, malleable, really not that noticeable, your scars are pretty much done healing. Same thing with the massage, but 6 months to a year for sure.
Okay. And how about not just for the scars, but the breasts? Because sometimes they get like stuck, right? Like that here, maybe at the bottom or at the top, and then cupping is done that way, right?
Yeah, because cupping is basically you're just passively stretching that tissue out. So you're stretching the collagen fibers, but they're an active. It's like a hemp rope. You got 4 different strands for collagen all bound together, and if you're not stretching and working that over time and just leave that rope sit in the sun, it's just going to stiffen up and harden. So yeah, you definitely have to.
Right. Agree with what she has said here in regards to bleeding.
Yeah, absolutely. To get to this is all uncharted waters for everybody. For us, in this country, us, in this world, doctors. We've never seen anything like this before. So the way we do things is going to be different. But it's going to be a good thing. Change is a good thing. You can never stop change and this will spur some positive changes. It really will. I mean, it's a
I,
disaster, nightmare while it's going on, but if we all go into this, in the long run, things happen for a reason, and we'll be better people. This will be a better planet when things are done. Then it's the way it is.
yeah, and I do. I mean, like to Danielle's point, I do hope that it really sparks the conversation of the importance of protecting our immune systems all the time, not just when there's an outbreak or not just when you're sick with breast implant illness or not when, any of that, like all the time we need to be protecting our immune systems. And I think that we've gotten so into, medicine and just treating things that happen and treating these underlying issues where let's go to the root cause and try to eliminate even having those issues to begin with. I'm really hoping it sparks that type of conversation after the dust settles.
Absolutely.
Yeah.
It's a good question. Initially what we're taught as surgeons, plastic surgeons, when you put a drain in somebody, or when you put drains in, or why you put a drain in, if it is an open space that you're draining, like area between muscles, or if you create a big open space, like taking an implant and capsule out, lifting somebody's skin up to do a tummy tuck, when there's a big open space there, you've cut across, blood vessels, you cut across lymphatics. Those open vessels are going to leak and ooze out serum. There's going to be some blood that leaks out. If you don't give the way for a body for drain it, that fluid's going to collect, and you're going to either, if it's blood, get a hematoma that you got to take back to the operating room quickly to fix. If it's a more delayed collection, it's more serum from the fluid that's in the blood collection that you get a seroma. So initially, we all left drains in until you hit about 30 cc's, an ounce for 24 hours per drain. So you would have patients keep log of everything. Initially taking implants out, my drains I kept in for about a week, 5 to 7 days, sometimes longer, until people hit that mark. Doing that, we had a lot of people that were really starting to stick down to their chest wall. So with having a drain in, it's really uncomfortable trying to get somebody to massage that tissue. You're almost defeating the purpose of putting a drain in, because if you're moving the tissue, you're going to make some fluid there. So that's when I started pulling drains out quicker, around the 2 or 3 day mark, especially if they had thinner tissue, so I could start massaging, getting the tissue moving. We probably have about, at the most, a 10% delayed fluid collection of seroma that I see back, but I'd rather have somebody be able to get their skin moving on their chest wall, because there's a little bit of fluid in there, which is a great lubricant. If it becomes too much fluid, I can easily tap it with a needle. I'd rather have the fluid to skin tissues moving on their chest wall than having a worse problem where everything's stuck, that potentially you need another procedure to release that scar tissue again.
Right. Okay. I feel like that might spark some more conversation down the road, but but as far as drains go, I had some previous questions about drains. So how come so some women get drains and some don't?
The ones, again, if I make a big open space, like taking an implant out and all the capsule, a reconstruction after mastectomy where everything is pretty much filleted open, you got a big raw area that's going to leak. Those are the patients that I put drains in. In my mastopexy patients, or somebody that's getting a reduction where they're getting their implants out, where they have still a lot of their own tissue, if I can take the capsule out, completely, and that capsulectomy is easy, it's not too bloody of a dissection. Also, when I'm doing that breast lift or a breast reduction, it's a much bigger open area, so it's very easy to see and make sure things are really dry. So if it looks dry enough, yeah, then I take a chance of just packing that cavity with the patient's own breast tissue to fill in that dead space. Then I don't put a drain in.
Okay.
Usually I get away with it. Have I had people get seromas, hematomas because of not draining them? Yes.
Okay.
And again, too, putting a drain in, you can still get a hematoma or seroma. It doesn't stop you from getting one.
Yes. Okay. I have seen that as well.
Early on when I was just starting plastic surgery, we did some experiments with wound healing, and we did TENS units with different polarities on wounds and all. And with some of it, you could see some significant healing. So, microcurrents, TENS units, there's a lot of good studies out there. They can help with wound healing and scar massage and tissue scar management, put it that way. So, I mean,
Okay.
I believe in them. There's minimal to no risk in using those. I would definitely use them.
Okay. Good to know.
of all of the breast implant illness patients that I've taken implants out of, total capsulectomies and removing their implants, most of the augmentation patients have not had over-release of their pectoralis muscle. And if you think of your pectoralis muscle, I mean, there's always a point where it inserts, which is into your humerus. The muscle goes across your clavicle. It's almost like a rectangle or a polygon. You're going back to geometry, but across your clavicle, down your sternum, there is a little back cut where it attaches to your rectus muscle, and then the bottom goes back out towards your armpit. When you put an implant in, it's just releasing that little bit of attachment to the rectus muscle, so the whole side flips up, sort of like you're lifting up a whole side of the bed of a sheet versus just trying to tuck in from the top. You release that part so you get more lower pole projection when you're putting the implant in. That as soon as you release that muscle, that little part that was stuck to the rectus muscle, it just becomes that leading free edge. There really isn't anything you could, tack back down to the chest wall that would make any difference as far as function. Unfortunately, you do see some people that have had implants in, they're basically skin on top of the implant, almost like a subcutaneous mastectomy for breast cancer. And if there is a significant amount of muscle release, now you got skin now on ribs, you can see more of a contour deformity. But being able to reattach that muscle to the rectus muscle and have it work, you'd have to mobilize somebody's shoulder for about a good 6 weeks. It'd be like having like a rotator cuff repair. I mean, you'd be in an immobilizer for 6 weeks and then some intensive therapy to get that shoulder back. So I haven't seen that many muscle repairs. The few I've done have been in reconstruction patients where they did release way too far up the sternum that I was able to reattach some muscle. Muscle being stuck to the chest wall, I mean, that should be something obvious on physical exam by, the 2-week or even 6-week mark out when you're seeing somebody back and checking their range of motion in the office. I mean, the patient would feel it too. I mean, you feel almost like a frozen shoulder or rotator cuff injury that you did not have full range of motion, in your shoulder. Most
right. And what do you do for that at that point?
If it's stuck, physical therapy, just aggressive physical therapy.
Okay. And since you just mentioned implants, just for the viewers, how many implants are you still doing? Like, do you see many augmentation patients at all?
Breast augmentations, I think total last year was about 6 consults and probably 2 patients that went to surgery. And everybody asked me the question. The main reason I still will do it is not necessarily, and again, too, if you look at the volumes, it's not something that I'm making tons and tons of money operating on only 2 patients a year. I have a lot of patients that I did put breast implants in. So I want to make sure that they know that I am still out there, that they can come and see me for follow-up, especially what's going on with the ALCL and breast implant illness syndrome. Also, as a physician, it's all part of my training. It's paramount that I'm able to see these people and educate them. Besides all the standard things that they hear from any plastic surgeon, I want to make sure that they understand about the risk of breast implants, that they're a temporary device, about breast implant illness syndrome. Interestingly, of the patients, the few people that have come in for consultations for augmentations, the one thing that always makes them think twice and scratch their head, it's not that they can get cancer from their breast implant or that they get sick from their breast implant, is when I tell them that it's temporary and depending on their age, you're going to need 2, 3, 4 more operations in their lifetime. And they're like, wait a minute, I just didn't think about that. That's usually what stops people from getting implants.
It's amazing that's the point that gets them.
It's crazy how, undereducated people are. And that's the main reason why I want to see them, because if I can make somebody think twice or know for sure what they're getting into, then I've done my job, no matter where they go.
Absolutely. It's great that you do full disclosure. So